Good evening. I am Dr. Jeffrey Sterling. On behalf of the Alpha Phi Alpha General President, Brother Dr. Willard Slonzer III, I am the Surgeon General for Alpha Phi Alpha Fraternity Incorporated. Typically, I'll begin these webinars of ours by talking about how excited I am for the conversation we're about to have. This evening, I'm a bit distraught and perplexed at the need to have this conversation, and you'll understand why pretty shortly. Here's a spoiler alert. Black women are it's about 3.3 times more likely to die from a pregnancy-related cause than white women. And there are a lot of different considerations that cause those disparities, such as a variety of the quality of healthcare, higher risk at birth for the chronic conditions that lead to this, structural and implicit bias and racism. One of the things that I find particularly intriguing is the public health discovery that many of these discrepancies go away when you control for the race of the treating physician. And this feeds into the public health premise that culturally sensitive and culturally specific care actually results in better outcomes for community of color. And that's medical's jargon for the fact that when you have Black physicians taking care of women in these examples, many of the disparities are dramatically reduced. So that's what we'll be talking about today, and I welcome you to the conversation. I'd actually like to once again welcome back as tonight's moderator, Alpha Phi Alpha's Deputy Surgeon General for Family Health. Brother Dr. Victor Narcisse III is a spring 1990 initiate of the Rho Iota chapter of Alpha Phi Alpha, and he is currently active in Alpha Eta Lambda chapter. He practices at the Houston Methodist Hospital as the Associate Division Head of Hospital Medicine, and he is the Director of Clinical Research in the Division of Hospital Medicine. Dr. Narcisse is board certified in internal medicine and geriatric medicine and a fellow of the American College of Physicians and the Society of Hospital Medicine. He will introduce tonight's outstanding panel. Please feel free to share, follow, and like, and please also ask your comments and questions. Brother Dr. Narcisse, I'm turning it over to you. Have a great show.
Good evening. Thank you for joining us this evening to talk about something that is also important. I'd like to welcome two individuals with esteemed backgrounds that are both brothers of Alpha Phi Alpha. First, Brother Byron Gautier. He is from my home chapter of Alpha Eta Lambda. He serves as the national chair of the Alpha Phi Alpha Fraternity March of Dimes Committee and is the liaison between Alpha Phi Alpha and the March of Dimes. He's got a Bachelor of Science from Florida Agriculture and Mechanical University. In his day job, he's a senior sales enablement manager at Aspen Technology here in Houston, Texas, where he works in design, implementation, delivery, and management of sales, enablement, and training programs in an attempt to align with corporate and regional goals. He has a lot of experience and is helping oversee in his role with the March of Dimes implicit bias training for healthcare providers. And I thought that he would be a great voice to this conversation. Thank you, Brother Gautier.
Thank you for having me, Dr. Narcisse.
Additionally, I'd like to introduce Brother Gonzalo Rodriguez. Brother Rodriguez is a generalist OB-GYN doctor, obstetrician gynecologist, who works at the FQHC Center for Family Health, Women's Health, and has a special interest in infant morbidity and mortality. He's spent much of his time in Kalamazoo, Michigan, and is a fellow of the American Congress of Obstetricians and Gynecologists. His medical training was initially at the University of Cincinnati College of Medicine for medical school. His residency was at the Medical Center, Delaware, Christiana, and Wilmington Hospital for his residency. And he has a track record of working with hospital and healthcare industry to promote better outcomes. Brother Gonzalo Rodriguez, we welcome you to the audience as well.
Oh, thank you very much. I really am excited about tonight's presentation.
Tonight we're going to talk a little bit about disparities in maternal health. Approximately 700 women die in the United States each year as a result of their pregnancies and their complications. And I find this so disturbing because I really feel that this should be a much smaller number and there shouldn't be the kinds of disparities that we've heard. Brother Rodriguez, do you see the worsened pregnancy-related mortality in African American women?
Well, I appreciate the opportunity for this conversation because, as you know, when you work in a particular hospital or a particular region, sometimes you don't necessarily get the full picture. But when you collaborate with colleagues around the country, we have unfortunately seen a rise in maternal mortality, mothers dying in that interval of time of their pregnancy. As an obstetrician gynecologist, we are germane in making sure that we have the healthiest situation for mothers and for their babies. And it is just very frustrating in our United States of America that despite all the resources that we have, that we see this increasing number of maternal deaths and the disparity between African American mothers and the majority community of Caucasian and white mothers. It is, as you suggested, more than 4 times that rate. And it is actually directly related, after looking at many papers and many studies, is directly related to structural racism and an inability to understand and communicate with our people. So I'd like to let you know that there are many aspects, and I want to stay within the context of your questions, but each one, I would be happy to speak on each individual area, because this mortality rate, as you see on the screen, the African American mortality rate, that means mothers that die in and around pregnancy. We, as obstetrician gynecologists, we'd like to be able to say that we love to be able to take care of people pre-pregnancy planning, through the pregnancy, and up to 6 weeks, 42 days after the pregnancy is over, because we know that complications can arise up to 6 weeks after a delivery. It doesn't just end with the delivery of that child.
In medical school, we often talk about different outcomes for pregnancies based on age. And I wonder if we see the same trend. I would imagine that, in my mind, I can imagine that teens would have a different kind of outcome of their pregnancy than the individuals that are a little bit older. Do you see the same kinds of disparities amongst older individuals with advanced maternal age, or is that sort of a different phenomenon?
Well, we are seeing much more mature, I won't say older, but mature women having children. The trend has been, because of the society stressors and pressures, that many women are delaying their childbearing until they are financially settled. That has been one trend. So when you look at the common denominator, we find that, yes, as we get more mature, you're going to have more problems associated with the pregnancy. And as a result, we're seeing the same type of disparities are presenting themselves in that more mature population. I didn't mean to skip, but it's not only more mature, but it also translates to across educational lines, social economic lines. The disparities are profound, and the numbers themselves bear them out.
What kind of a disparity are you talking about? Is it the same kind of a 3 to 5 times higher than other groups, or is it something different?
Well, one thing that's very startling is that the African American mother leads the disparity list when you look at Hispanic, Latino, Pacific, Asian, Caucasian. We are saying that this is compared to the problems that we're seeing in the Caucasian population is 3 to 4 times higher than that in that population, but everybody is increasing. So what I will tell you is if you look at the trajectory that we're losing the battle when it comes to, number one, improving the health care for women. The whole group is getting worse. But we, meaning African American ladies, still there is a wide discrepancy that cannot be explained by anything else alone except a racial bias or inability to be able to connect, or inability to listen, these are things that we feel that we can preventable mortality in our female population.
You see the same kind of a thing in other communities and in other countries and in other parts of the world, or is it limited to the United States, where women of color seem to have a worse outcome?
Okay. What I'd like to do is, I've had the opportunity to do and have an interest in global health studies, and this is what we're trying to provide is that the United States, the United Kingdom, Canada, there are systems and countries that are considered very prosperous. And in that tier, we'd like to be able to compare apples to apples when it comes to resources. The one thing about looking at the United Kingdom, for example, is that they have universal health care, or that they have a different way of payment for their care for the citizens of those countries. And we try to look and see if there is a big difference. However, just because you go to the United Kingdom doesn't mean that there isn't structural racism. The fact that there continues to be a great disparity between maternal fatalities, maternal deaths in all of those countries, but the disparity has not changed regardless of the country when you compare apples to apples compare countries that are well-to-do and wealthy. That disparity continues.
Well, let me take a step back. I really want to understand better, because I think that a lot of individuals in our country feel that pregnancy is a very, very normal thing, probably is a very, very safe thing. And it often is, but I'm not sure that it always is. Can you talk a little bit about the kinds of complications that any woman might have?
Okay. The process of childbearing is considered a natural, and you intuitively feel that it's a natural situation. That's why when there's a problem that exists, it's so glaring, because things can go terribly wrong very quickly in obstetrics. I would like to, let just be able to focus on some of the underlying problems that we see in obstetrics. And what we do is, when the person comes in for prenatal care, there is a discussion that allows us to pinpoint whether there are risk factors in that individual, because in that 9-month interval, the person may express some underlying disease process that was not present or not even known prior. So what we find is that is the reason why so many of the educated physicians in their course, they will say, well, if the African American population has certain problems that far exceed other populations. One is hypertension, and that is one thing that we are struggling to be able to do a better job of, not only identifying what hypertension is, but by virtue of discovering that there's already in-organ damage. Number two is the diabetic scenario that puts a pregnancy in a higher risk category. The toxicity of sugar, the toxicity of high blood pressure. When you're forming new vascular networks with the placenta and the attachments between the maternal system and the infant, all of those types of constructs and pathophysiology is very important, because when that mother is pregnant, it is the ultimate test in the respiratory system, in the cardiovascular system, in the heart, as well as the kidneys. Those areas will be changing in a way that has never been done before. So if there's anything underlying to compromise or to affect those systems, as that person gains weight, as that person proceeds through their pregnancy, that is why there is such importance in encouraging a collaboration and a partnership and a trust between patient and physician with those prenatal visits. One thing that I find that is very fascinating is that many times patients are coming in after 12 weeks for their first prenatal visit. And embryologically speaking, that placenta and the infant has already been exposed to whatever has happened has happened. The pre-pregnancy planning, and I know it is kind of the anti-freedom push over the years to say whatever happens, happens, but if we can be intentional, if we can really, the whole specialty has been beating the mantle about the importance of pre-pregnancy planning. And I will see maybe one patient every 6 months that would ever say, yeah, I'm coming to you because I am planning a pregnancy. It's most of the time it is coming to see us after the pregnancy is ongoing, where the pathophysiology of the body has changed to the point where it is very difficult to be able to diagnose a hypertensive patient in that respect. So I just would like to just be clear about the challenge of pregnancy, how that goes, how important that is to the genetic component, the understanding of where that person's family, sometimes it's important to reach out and ask a person. In my medical education, in our short time, you say, what, you have sisters? How did your mom do in labor? How are the outcomes of your family? To try to understand that the apple does not fall from the tree.
Well, that was a very, very passionate description, brother. It's clear that this is the space that you spend a lot of time thinking and working in, and you see these complications firsthand and feel that so many of them are potentially preventable. Are there any other specific ones that you worry about in terms of diagnosis that are preventable that you'd like the community to know more about?
Yes. Right now, there are many changes in the hospital system of care. And really, it is important for us to be active as a community to gain traction from legislators and politicians and to be able to provide the fabric and the resources that hospitals need to take care of emergency situations when they arise. We find that there are some hospitals that are very open to all patients. There are others, when I worked in some hospitals, they would turn patients away or they would discourage them from coming based on their insurance or their own personal resources. Now, from a business model, and if you can think about this just for a minute, you're coming in and you have a lady who's delivering, probably about 30%, only 30% of maternal mortality will happen at the time of delivery. Most of the complications have happened after that period where the patient is discharged to home. But in that 30%, I have worked in facilities and hospitals that did not have all the resources to deal with all the complications that can happen in a delivery. So is that a business model to be able to say, I'm not going to have these resources because they're too expensive and they happen here in a too rare a circumstance? And what hospitals can handle every situation is germane to being able to provide the best quality care. If I've identified that there are risk factors, then this is in Michigan, this is where the patient is better served at a hospital that can handle all of the complications. And in order to be able to do that, we need to make sure that we are communicating, we're letting the mother know, the family know, and provide the resources to be able to accommodate that individual, whether it be transportation. We found in Mississippi, on that coast, that there was a problem in that peninsula about getting across state lines. Even though I was an hour away from a major center in New Orleans or a major city in Mobile, transportation was an issue. So we had to, as a unit, put our resources into that transportation mode. So I think that if we can disclose or open up some traction with regard to how patients are doing at individual hospitals, this might provide an open textbook into understanding which hospitals can handle the highest risk patients. And if our patients are at the highest risk, they deserve to be going to the we don't need to be sending high risk patients to hospitals that have poor outcomes. We need to be able to balance that. No sound.
Is this part of reproductive justice that some communities have a different capability than other communities?
That is correct. It really is a discussion with exposure. We have communities, and our communities, they're built around places that have higher exposures to pollutants and as a result have, for example, asthma problems and not having fresh food and nutritional problems. I mean, these are areas that is all encompassing, but that's why as a fraternity, we have work to do. And we are really focusing with the talents that we have to be able to drive each one of these components and each one of these areas simultaneously, because the urgency is now.
We see that. Can you talk a little bit about some of the other opportunities to improve the social determinants? Would increase access to insurance or providers be of assistance? Certain kind of providers?
Yes, I believe that right now it is important to have physicians that are committed and not afraid of our people. Number one, I'm just, I don't want to scare anyone, but as a women's health provider, and you feel that you work many years to be able to be competent and board certified and those types of entities, but the real fight begins when you see the colleagues and the toxicity that exists with some of the physicians when it comes to the teamwork, the collegial teamwork that it takes to take care of the whole person. And so I think that we need to just beat that mantra. We would like to see more of us in medical education. Number one, we need to be able to train, educate, and bring people along who are truly passionate and committed to making a difference in our communities. And I've been working in that area for a while, whether it be on admissions committees or at least being on different task force to be germane. But the urgency, it sometimes trickles from the top down. I mean, we really need to be able to not be more visible, regardless of, I don't feel like I need to be tired, because if someone were to ask me to be their mentor, I would be accessible to them just because they pose that interest. But if we're so caught up and overwhelmed with having a large number of people who are highly frustrated with the system, we're looking at a lot of burnout with those physicians. So we need, I think, would be helpful to have a greater number of people to be able to share in this push, share in our efforts to be able to make a difference, to be able to turn the tide, because I want to emphasize most of these mortalities can be prevented. When we look at these cases after the fact, we look at information that was either not recorded, not listened to. The patient, you know, uh, has gone down a pathway of critically um, unsurvivable situation. The last thing I want to point out is that even though pregnancy is a normal situation, but if you were not being pregnant and you would lose just the mere blood loss at a normal vaginal delivery, it would be considered a hemorrhage. If you had a C-section, you would have 2 times a hemorrhage. At least 1,000 cc's would be about the average for a cesarean. So when you find that a person is entering in a hemorrhagic situation, which is the fastest way for consumptive coagulopathy or disseminated intravascular coagulation state, we need to be on our P's and Q's.
So, there are several studies that come to my mind that I've encountered over time. One was a study in Florida where they looked at mortality for African American newborns and found that it was lowest when those mothers were cared for African American physicians. They really suspected that there was a benefit to a culturally competent provider as a big piece, and this was an important factor. As we've heard several times, we worry about individuals with low access to insurance and healthcare. We worry about individuals who are of low income. We worry about individuals who are at the extremes of age. We worry about individuals with lots of severe conditions. But even after you look at all of that, it's clear that individuals of color seem to be less likely to receive the routine medical care, routine medical procedures, and as a result, experience lower outcomes. And so there's much work to do in this regard, much education, and I appreciate that. We wanted to talk a little bit about some of the things that Alpha Phi Alpha has been doing in trying to improve education and awareness. And I'd like to ask this question to Brother Gautier. Could you talk a little bit about the partnership between March of Dimes and Alpha?
Certainly, Dr. Narcisse. Back in the 1980s, again, almost 40 years ago, the Brothers of Alpha Phi Alpha in Chicago developed a program aimed at preventing teen pregnancy from a male's perspective. And so that charge, that conversation for a critical issue of how do we keep babies from having babies, most of those programs were geared at young women. And so Alpha Phi Alpha took the opportunity to take it on from a male's perspective. And that program has grown so that each year, tens of thousands of young men are mentored and educated on the subjects of being a responsible person sexually, making sure that we are preventing teen pregnancies. And so that through that program, through that efforts, our partnership was grown because at the time, it was very important for us to understand the different components of premature awareness and what would cause premature births. And looking at the age of the mothers was a part of that process. And so now we've come full circle, and that we are still efforting to prevent teen pregnancies, but our partnership has grown from that standpoint. We're one of the national partners that does a lot of fundraising during the March for Babies campaigns, where we're out there raising money to support the mission of the March of Dimes.
Can you tell us a little bit about the programs that you're supporting?
Sure. So number one, a big part of the money that we raise goes to research, right? And so finding ways to prevent prematurity, what causes it, how can we prevent it, but also to improve the outcomes when babies are born premature. So research funded by the March of Dimes produced the knowledge about surfactant that improved the outcomes for babies that were born premature. Even in prenatal care, research funded by the March of Dimes talked about folic acid and how that could improve those outcomes. And so a lot of those funds go to research, But there are also a number of programs that the March of Dimes has, thinking about how we're involved in the neonatal intensive care unit, where we're working with families as they begin to understand, to work with those families to help bring those babies through that process and have a positive outcome. And now we're talking about maternal health care and maternal outcomes. And so not only is it sufficient enough for our babies to be born healthy, but we want the mothers to be born healthy as well. We want them to get their 40 weeks, but we also want to have a positive outcome for both the mom and the baby.
So, what got you involved with the March of Dimes initially?
Well, my girlfriend at the time and now wife, when we got married, I was blessed with also having a new daughter. And so when having our conversations and talk about family planning, it was noted that um, my my daughter was born premature. She was born at 32 weeks, less than 2.5 pounds, and so she spent the first few months of her life in the NICU. And so that got me to thinking and positively about what we do with the March of Dimes, and became an advocate at that point in time. And when I became a member of the fraternity, one of the first projects that I worked on was a Project Alpha at Kashmir High School here in the Houston neighborhood, where we really talked and worked with those students there and those young men about preparing them for life and about preventing teen pregnancy. And so those are some of the early conversations and things that promoted me to be more involved with the March of Dimes.
One of the questions from the audience asked about how we're incorporating reproductive justice and these issues into medical education. Brother Gautier, I understand that you're doing some work in this regard with implicit bias. Could you give us more information about that?
Yeah, so sure. Let's talk about implicit bias training. So it's a phenomenon. I can remember when I moved from Florida to New York, it was all about diversity training. But we've come full circle. We're beyond that now, I should say, where now we're talking about diversity, inclusion, and equity. And we're discovering that even in our healthcare scenarios, that implicit bias can find its way and have an impact on the outcomes of maternal health. And so if you think about the process that a woman goes through from the time she walks into a doctor's office or a hospital or a doctor's office building, the receptionist that she deals with, the nurses that weigh her, the technicians that support her, all those different elements, if the biases are felt by that mother, that it doesn't have an impact on the welcomeness and the environment that's been created by that office space. And so we spend a lot of time and efforts in crafting a program that does implicit bias training for healthcare professionals so that we can improve the outcomes for the maternal health.
Can you explain a little bit more about implicit bias and how that might affect someone's health care?
Sure. So when you think about the patient-doctor relationship, and I'll use my own wife as an example with my son was born. As she was getting on, and we were very cognizant of what had happened in the past, and we were very careful. We had a specialist that we were working with. And there was a certain point in time where my wife was like, I need to be on bed rest because these different factors and these different side effects are occurring. And so the doctor was like, oh no, you're strong, you're healthy, you can handle the pain, you're young enough that this is not an issue. She did everything but say you people in this conversation, and was very stubborn about her approach and care. And so what we find is that even in those scenarios where we understand what explicit bias is, when someone definitely steps over the line from a racial standpoint, but it is the background, the cultural that people have grown up with, the things that have they formed their opinions that sometimes bear themselves in a way that can marginalize, that can denigrate, but more importantly, set the stage for other types of biases to be prevalent and to grow and prosper in that environment. And so when you take on implicit bias, what you're doing is that you're finding a way for us to not only think about the care of the mother, but we also think about the care of the entire family and the environment that we're putting forth, so that everyone feels that they're welcome, regardless of their race, their culture, their economic status, that they have that same level of care to get those positive outcomes.
So implicit bias leads to structural racism. Is that a fair statement then?
It can lead to structural racism. More importantly, it can lead to microaggressions. And that is where we find where the incidents can put a potential mother at risk. It adds on additional stressors. And those things definitely can have a negative impact in terms of the birth outcomes. And so it also breeds the ground so that racism and systemic racism can take hold. And so having our ability to address these concerns, to be able to teach people to recognize not only when implicit bias is there, but how to self-correct, how to self-assess, and more importantly, how to be an ally, so that when you see a coworker or when you see someone that is exhibiting signs of implicit bias, that you have the proper tools to be able to coach, advise, and
Yes,
to hopefully correct the situation so that a positive outcome can take place.
that is so true.
This has been a very sensitive topic, and a lot of my colleagues will say they don't have any biases. Is it normal or abnormal to have a bias?
Well, everyone has biases. I think it's where you were raised, how you grew up, what you were exposed to from a media perspective, the images that you see on the news and on television. All these things form a basis for how we act, how we react, and how we judge and how we move. I feel a certain way about people who put sugar on their grits. I mean, that's a bias that I have. But not to trivialize it, but we all have biases. But it's when those biases take advantage of other people or marginalize it, as I mentioned, or have a negative impact in your abilities to be able to service or take care of those folks. That's when those biases become a problem.
Thank
In my space, we often talk about the CARES framework, where we implement collaboration, affirmation, show respect, demonstrate empathy, and provide support. And this is the one of a multitude of strategies that individuals and organizations can implement to try to address these issues of implicit bias. And one of the questions that came over the chat was talking about cultural humility. And I think that that's one of the things, that concept, practicing cultural humility, that I understand where I come from. I'm very proud of my community, but I'm also aware that my community doesn't have all the answers. And if everyone's community sort of had a similar approach of humility, then we could better respect the opinions and perspectives of so many. And that leads to a culture of equity. And when an organization commits to a culture of equity, we just really see better outcomes in healthcare. And that really applies to so many different areas of life. Brother Rodriguez, you've spoken so passionately about your experience. It sounds like you've seen how bias affects healthcare as well.
In so many ways. And right now in the state of Michigan, in order to renew your license, they are requiring you to at least visually go through a number of videos that speak to the issues that our brother was talking about with regard to the individual biases that occur in each individual. You have to first acknowledge that you have them. And I really appreciate your point of view. And many people will say uh, that are physicians, it just seems like the higher the educational norm, the construct that allows you to push forward, some of those make one more resistant to being open-minded, that they somehow uh, fixate to saying that their way is the only way, where we are trying to interject that acknowledgement of these biases is the first step to being able to know how to not allow that microaggression to present itself. Uh, or it is so important, especially when it comes to maternal health care.
Outstanding. I'm so impressed with the work that both of you are doing at the front line and as an organization to try to improve health outcomes. Brother Gautier, can you tell us where we can learn more about your program and how individuals might implement it in healthcare space or in other organizations?
Sure. If you go to the March of Dimes website, that's www.marchofdimes.org, or you can reach out to one of the local offices. The staff is very well versed in implicit bias training. To this point, we've trained over 35,000 healthcare professionals, and the feedback has been overwhelming, to the point now that there is the potential for this program to be adopted and to extend beyond healthcare. And so we're definitely looking forward to those opportunities to engage not only healthcare professionals, but others who want to improve in this area.
Outstanding. Brother Gautier, can you just give us your final thoughts on what you'd like individuals to do to promote equitable maternal health?
So if you are a father, or if you are an expecting father, if you are someone as a daughter or anyone that is going through this process, be that protector, be that advocate. Understand that these things can happen. And it's important for us to recognize them and to address them. We're not always in the room when the examinations are taking place, but we can have the conversations. How do you feel? How did you feel about the care? And so we want to make sure that we're attuned to make sure that there are no stressors, that there's a positive environment, and that the person is going to for their care, so that everything that we can do, and we talked about earlier on this call that a lot has to go right to have a positive birth outcome. And we want to make sure that we give the mothers and the babies the best chance to be successful at that. And so it's more than just research, it's about programming. It's also about things like implicit bias training that we're doing with the March of Dimes that's moving the needle forward to improving maternal health.
Outstanding. Brother Rodriguez, is
Yes.
anything else you'd like to share that individuals could do to help promote equitable maternal health?
Well, I just really appreciate the conversation right now, but we really, as brothers, we are really focused and should really emphasize the importance of the paternal input into prenatal visits and being that solid backbone of the family. Right now, I have found that sometimes when both parents are working or a lot of times we focus on prenatal visits for a mother, with the advent of phones and being able to have a Zoom conversation, we can at least get positive feedback from men, even though they may not be present in that room. They can be present in terms of asking questions. There's, the white coats and that 10 minutes and 20 seconds scares a lot of people. That heightens the problem of this, of implicit bias. How are you going to reduce those anxieties in the short term? But the presence of men is always helpful to take things down a notch and to be able to insist on the communication and someone on your team that's going to listen to you. I appreciate the time.
Outstanding. I'd like to just include one other thing. Politics and advocacy is something that I think is ever so important. This is a time when we as a nation are going to be asking big questions about the direction, and I would encourage individuals to get involved. I'd like to encourage and thank those that have gone before us, those who are working so hard. Here in the Houston area, one of the thought leaders in this is a member of Alpha Kappa Alpha Sorority Incorporated, Sean Theory. I'd like to give her credit for the work that she's done. And there's so many others, but I really like the idea that you brought up of men participating at a higher level. And we think of pregnancy and maternal health and infant mortality as issues that are not male issues. And I think that the efforts that Brother Gautier and Brother Dr. Gonzalo Rodriguez have brought forth, or make it clear that these are the issues that men need to pay attention to. We'd like to thank each of you for participating, for your questions. I'd like to thank my panelists for their time this evening. This would not have come to you without the support of our General President, Lonzer, and of Surgeon General Sterling that you'd heard from at the beginning. We'd love to hear you and have you come back on September the 1st, where we'll be speaking about managing pediatric patient needs, and September 15th, where we'll be talking about suicide prevention. We wish all of you a blessed night, and continue to speak out, continue to advocate, continue to participate with your elected officials so that your voice can be heard. Thank you so much.